Hi, my name is Lynn Herr, and I'm here today to present supporting and strengthening families through home visitation. I also have with me Sophie French, who is the supervisor of the Pre to 3 program, and Mikkel Heron, who collects data and analyzes that data for the program. So Vanderburgh County is in southern Indiana. We are a population of about 180,000, with 15% of our population being that of a minority. Black, multiracial, and the Marshallese, which are Pacific Islanders, make up the most of our population. We did apply for a grant because southern Indiana has had a large problem with infant mortality. In 2014, our infant mortality rate was as high as 13.1. We have been able to lower that rate, and we did receive a $3.6 million Indiana state grant for home visitation to lower our infant mortality rate. So the Pre-to-3 program demographics look a little different than the demographics of our community. We do have a higher Black involvement in the program. We also, our average salary or income is less than $10,000, but we do not have a income cap on the program. We also take first time, second time, third time mothers. There's no limitation on the amount of children in the home, but we do only take intakes into our program prenatally and up to 90 days of age. And that is because of the curriculum that we use and the fidelity of the program. We have a high smoking rate. 38% of the folks that join our program and sign up are smokers. Southern Indiana does have a high smoking rate, but we are pretty proud of our outcomes, and we will discuss that as we go on with smoking. We do see women in the jail during their incarceration to be a safety net when they come out. We also see women in our drug treatment centers that allow us to also be a safety net when they're released from those programs. We see teens in the schools, also giving them support, and we see individuals in their home. Now, COVID has given us a little kink in the situation, and we are doing virtual visits on our phones, and then also doing them outside in person, making sure that we social distance and wear our masks. The program also looks at, and we collect all these data points, in which we'll discuss later, to make sure that we are serving the most vulnerable in our population. So HRSA has actually set forth some benchmarks for home visitation, and we wanted to take that into consideration on development of this program to have the best outcomes for our mothers and children. We know that they need multiple services, so on intake, we do find those other services that are needed by our population and make sure that they have referrals to WIC for home insecurity and food insecurity and others. We want to make sure that we have an involvement with DCS. DCS does involve us on the local level, and we become part of that safety plan. And the goal is to get that DCS, the Department of Children's Services here in Indiana, removed from that case. We also want to make sure that domestic violence is not included, and we do screen for that. We also want to make sure that our mothers are getting good care, and we do have a ACOG measurement of good prenatal care or sufficient prenatal care. And then we also want to make sure, and our goal is to make sure that these kids are ready to have the best outcome at school so that family goals are met for their children. So to provide these high quality visits in the home, we did receive this funding or grant funding, and we have calculated to serve 245 families in their homes last year. It cost us about $1 million. We will have the opportunity to resubmit for grant funding next year. And we have also developed a 501c3 for funding as well. And then we are billing Medicaid. We are the first program of community health workers and RNs to bill Medicaid in the state of Indiana. While it is only $22 or a little over $22 an hour, we hope that through our continued billing that we'll be able to get managed care to support this program at a higher rate.
Hi, I'm Sophie French, and I'm the Pre to 3 supervisor. And I just want to touch base a little bit about what makes our program unique. And a big part of that is the team that we have. We use a team approach to support our families, and we feel like it offers multiple layers of support to offer a lot of varied services. So we have an intake coordinator who meets with our families when they first come into the program and just assesses, where they're coming from, what their needs might be, and gets them connected to resources immediately. And then she gives them our cards of the nurse that will be assigned to the family, the community health worker that will be seeing the family on a weekly basis, and also if they're in need of social services, she'll go ahead and assign them a client advocate. And our families really like that. They like having the information about each of the providers on their team. They have their phone numbers and can text them if they need anything. As far as that goes, then the nurses come in to see the family anytime there's a medical concern, such as maybe baby's not gaining weight, maybe they're concerned baby's not developing well, or mom has gestational diabetes, has preeclampsia risks and has questions. And so we can be in the home as a support to answer those questions and also support, what's going on with them with their medical provider. And a lot of times their provider will contact us and kind of work with us as well. All of our nurses are lactation consultants, so they meet with the families that want to breastfeed. Some of them may not know and want more information, so they'll meet with them prenatally. And then they also go into the home postnatally as well and meet with the family to support them with breastfeeding, whether they have questions or having difficulties. And they'll also offer a postpartum screening based on the ACOG guidelines, just to make sure that mom and baby are doing okay before that 6-week postpartum check. The foundation of the program is really led by the community health workers that are there weekly because they're the real support that the family gets to know. They almost become part of the family. And they use what we call Growing Great Kids curriculum. And it's a wonderful curriculum. It is there to, as a support. Again, we don't preach or educate the family so much as we go through this curriculum together as a team, and they get to pick what they want to do, where they want to go with the curriculum based on what they feel like they have questions about or what's going on in their life. Maybe it's stress and they need coping strategies, or this is their first baby and they don't know what to do when they bring the baby home from the hospital. So it goes over a lot of basic care, social emotional development. We look at cues and communications in each section, physical and brain development, and then also play and stimulation, which is how babies learn. And the community health workers let the families know they are the child's primary developmental specialist. So they're put in the spotlight for that. It's always about the family and building the relationships between parents and the children. And then the client advocates will refer to when we know we've got a need that's going to take a little more time. Maybe it's housing, maybe it's transportation, or they want to work on getting their GED or go to college, or maybe they need help finding a job. So when we need a little bit more time and expertise in those areas, that's when we bring in the client advocate. Last piece of that team is our data analysts, and we have several, and they are the ones that put all the information that we gather from our families and from the things going on with the program and really break that down for us so we know where we are, where we want to go, and how we want to improve. We have so many success stories in the program, but I wanted to touch on one that was referred to us when mom tested positive for THC after she had had the baby, and was referred to us by DCS. And we know sometimes that doesn't always go well. The families aren't very happy. And we tell them we're a voluntary program. We're just here to support you so that you can be successful. And with this particular family, mom and dad had been homeless, not holding down a job or having a very stable home environment. But they really wanted to do better. They wanted to do better for their children, which is what most of our families want, right? And so dad got a job and mom stayed home with the twins. And obviously they ended up with a stable living environment with an apartment, and they loved the program and really got into all the activities and the fun. And then mom decided she thought she might want a career in something similar to what we do. And she decided she'd always dreamed of nursing but never thought she could do it. And she's now in college to become a nurse. So that's just one example of a family who's really thriving. The kids are above age level in development and doing really great. So what does the future hold for Preta 3? We hope we continue to grow. We are starting to expand into other counties and would really like to be available in our whole region. And then would eventually even like for the state to look at us as a model of success. As far as we also want to increase our partnerships and our collaboration, we're working closely with Evansville School Corporation and looking at ways we can transition our 3-year-olds, because once they're 3, we have to move on, and we want to make sure that they continue their success in future programs. And then also with funding, we want to continue getting funding. We want to continue billing Medicaid and having appropriate reimbursement. And also we have applied for the 501c3 to have a foundation to help support our future endeavors as well. And we are looking at longitudinal studies along, again, with EVSC, our school corporation, and then also some research. Right now we're looking at preeclampsia and aspirin therapy and how many of our pregnant moms that are at risk are having that as a treatment, and what do the outcomes look like. And we work with some physicians in a hospital in town to look at that. So a lot on our plate, and we're really excited to see what the future holds.
In order to collect data and track program outcomes for the Preta 3 program, we've chosen to use an electronic form building system to develop a series of forms that our home visitors use to collect data on each visit that they have with the clients. We chose this system because of cost efficiency and ability to customize forms so that we can collect as much data as possible. This information is taken and it's analyzed weekly, and we send progress reports to each home visitor and the Preta 3 staff to monitor how we're doing in program outcomes. Additionally, we run quarterly reports looking at our outcomes to see what things have changed and what areas we need to work on for continued progress. A few areas that I want to highlight since the program has started in 2018 is that our team has been able to reach 465 families, which accounts for about 10% of all babies born in Vanderburgh County in the past few years. Another screening that we look at closely in the Preta 3 program is adverse childhood experiences, or ACE scores, because we know that these can have a generational effect on families, and we like to teach resiliency in the Preta 3 program. And in addition to the ACE screenings, we also screen for postpartum depression, child development, intimate partner violence, and home safety in order to provide wraparound services for our families. Some of the program outcomes that we like to look at closely are our full-term and non-low birth weight babies, as well as our breastfeeding initiation rates, which are really high and have been higher historically than our county WIC rates. On behalf of Lynn, Sophie, and myself, I want to thank you for listening, and please reach out to any of us if you have any questions about the Pre to 3 program.